Everybody, welcome back to chapter 21. This is part 4 of a part 4 series on abdominal and gastrointestinal emergencies. And this section we will close out this chapter. So let's go ahead and get started. We're going to talk about some obstructive conditions related to the GI tract in this section here. So GI obstructions can happen anywhere from the oropharynx to the rectum. Rectal obstructions are common in young men and are often caused by foreign bodies. Esophageal obstructions, on the other hand, are usually due to foreign bodies and tend to affect children more so than adults. Bowel obstructions occur when the intestines cannot move material through the digestive tract. And there's two main causes for this. One of them is paralysis of the intestines, which can result from things like an infection, maybe kidney disease, impaired blood flow. Even medications can cause this, such as narcotics or anesthetics. The other is compromise of the internal lumen diameter of the intestines that are caused by maybe things like neoplasms, intestinal tumors, swallowed objects, strictures like we talked about earlier, hernias, the twisting or insusception of the intestines, or even a volvus might cause these things to happen. Esophageal obstructions are typically occur at either the upper esophageal sphincter or the lower esophageal sphincter. Typically the upper sphincter we see that involvement mainly in children. The cause is usually because of a small swallowed object, and it gets trapped at that upper esophageal sphincter that's located roughly behind the trachea in the esophagus. Now, adults tend to experience an entrapment of the lower esophageal sphincter, and the objects can be anything that fits in the mouth, and typically it's a bolus of food that gets stuck. In 80% of the cases, if the object manages to reach the stomach, it'll go ahead and pass through the GI tract. So once it gets to the stomach, it's usually fair game and it can make it all the way through. But if it gets stuck on the way down, there's a really good chance that it won't make it all the way through the digestive tract, even if it does eventually gets pushed on through. The main symptoms that we're going to see with these patients is dysphagia and drooling. The presentation is going to vary depending on the patient's age and how the obstruction occurred. Signs and symptoms may include things like difficulty breathing. They may complain of a choking sensation. There may be some drooling. They may have an inability to swallow. Could be some pain, maybe some vomiting, or even some gagging. About 1/3 of children show no symptoms until they try to eat something, and that's when we learn that they've got an issue. Care is primarily going to be supportive, but keep an eye on the airway for issues relating to that. Have the patient sit in a Fowler's position and manage the oral secretions accordingly. You may want to consider eye protection and things like a mask and a gown. These may be necessary, especially if there's any kind of risk of vomiting. It is appropriate to go ahead and check in the mouth and see if that object can be easily removed, but don't force it and don't try to reach when you just can't get it. Otherwise, just keep the patient calm and allow the emergency department to handle the removal process. If there's an obvious airway compromise, you may have to consider more aggressive interventions and more aggressive airway management. Glucagon, again, is one of those things that we could consider if it is within the protocol and medical direction approves that, because glucagon can relax the esophagus, the musculature of the esophagus, and it may allow that object to pass on down into the stomach. But once again, this is going to be protocol dependent or under direct direction of medical control. And there is an off chance that you may not carry enough glucagon on the truck to be able to accomplish this. If the object is removed on scene, encourage the patient to continue to seek medical care, whether that's that we transport them or they go on their own. Post-operative adhesions are the leading cause of small bowel obstructions. So someone's had some kind of surgery, some kind of bowel-related surgery, and they've developed an adhesion, from scarring or something along those lines. What happens is they narrow the intestines and limit the intestine's ability to dilate, which makes it difficult for food and things to pass through. Causes can include things like cancer, maybe even Crohn's disease. It could be a hernia through the abdominal wall, or it could even be a foreign body obstruction in there, something that's been swallowed that's not digesting and it's kind of getting stuck. Signs and symptoms, they may have some crampy intermittent abdominal pain. They could have, the usual diarrhea, nausea, vomiting, and they may have an increase in pressure that leads to more peristalsis, trying to push things through. Constipation could be the key too, so you may have diarrhea or constipation. Hyperactive bowels is typically an early sign, and then those bowels will become hypoactive later on. They may have a fever, especially if the bowel has ruptured. Tachycardia, there may be electrolyte imbalances, and again, sepsis can come into play if that bowel ruptures and time has passed, where they get peritonitis and then it develops further on into sepsis. Finding out if they have a history of abdominal surgery is important. If they're not able to relay that information to you, it's important to go ahead and visually inspect the abdomen and look for scars. Obstructions can occur decades after that particular surgery, so the surgery doesn't have to have been something recent. It could have been a long ago surgery, so keep that in mind, that these can develop over a long period of time. Can lead to localized changes such as swelling or even some ischemia that we need to kind of be aware of and look out for. Our care for these patients is primarily going to be supportive, as it is with most GI patients, but we're going to focus on sepsis because the concern is that the bowel ruptures and leads to peritonitis and sepsis. So monitor blood pressure and, of course, perform volume resuscitation as needed. Dopamine might be considered if the patient develops a severe case of septic shock. We may need to place an NG tube to decompress the stomach. Antiemetics may be necessary. And of course, we're going to provide fluids as necessary for those patients that need it. In the hospital, they're going to give antibiotics. They're going to do some imaging studies, and they very well may have to do some surgery. Quite often they do. These typically result in some kind of surgical intervention. Large bowel obstructions can happen from mechanical blockage or a narrowing of the colon because of other causes. The most common causes that cause these blockages is, of course, colon cancer, diverticulosis that we talked about, or even a volvus where the colon actually just kind of twists on itself, kind of like wringing out a wash rag or a towel. It kind of twists. Imaging is the key to figuring out exactly what's going on and how severe the issue is. But if left untreated, the blockage can cause the intestinal wall to break down and cause sepsis, and they may lose a large portion of their colon in the process. If the cause is cancer, it might result in things like fecal discharge from the vagina or something like that because it ruptures the wall, or even where it ruptures the bladder and there's feces in the urine. With large bowel obstructions, the signs and symptoms to watch for include things like abdominal pain, which we see with most things. Nausea, vomiting is pretty common with a lot. But this distended abdomen is a little new to some of the signs and symptoms that we see. Absent bowel sounds, and then of course signs of peritonitis is an indication that the bowel has ruptured. If there's also unexplained weight loss, it could be related to a colon cancer. And a gradual increasing in difficulty of bowel movements is also a clinical sign that we want to keep an eye out for, or get a history of to find out what's going on. Management is going to be similar to that of small bowel obstruction treatments. Remember, it may require more aggressive fluid resuscitation, and we're going to keep an eye out. We're going to focus kind of on pain management, managing their nausea with some antiemetics. But we're also going to keep a really close eye out for signs of developing sepsis or peritonitis, because those are indications that the bowel has ruptured and it's releasing toxins, into the abdominal cavity. Abdominal wall hernias, and this happens when an organ or structure kind of pushes into an adjacent cavity. With abdominal wall hernias, typically what we'll see that it pushes through the musculature of the abdomen, and it could be just fat that pushes through, but it also could be an organ or intestines that push through into that. And this picture kind of shows that. It's not a really great picture, but you can kind of see that big mass there that very well could be intestine kind of weaving in through that. So the way to check these hernias is you place your fingers over the patient's lower abdomen and ask them to cough. If there's a weakness in the abdominal wall, you'll kind of feel that bulge. This is a fairly common thing. Over about 1 million hernia repairs happen each year in the US. It's not at all uncommon for people to have small herniations that don't require surgery. Once they reach the point to where that you have protrusion of organs into that or through the wall, then obviously it's going to require some surgery to fix. Any number of things can cause a patient to have a hernia, but generally it's associated with the increases in intra-abdominal pressure, such as that happens with really obese patients that stand on their feet a lot, or the ones that do heavy lifting. Straining, having bowel movements can contribute to this, and the things that you don't necessarily associate with this, but chronic obstructive pulmonary disease, or COPDs, can lead to this as well because of that increased pressure. Remember, they begin to rely heavily on abdominal muscles to breathe, which can lead to the increased risk of them developing a hernia. 4 main types of hernias that we typically see. The reductible ones, these basically return on their own. They can be a little traumatic when you first see them. Patients don't usually feel any discomfort, but when they kind of bear down or something, this thing just kind of pops out, and then it goes back when they stop. An incarcerated one is just what it sounds like. It's when the organ or tissue kind of gets stuck in that position and it becomes incarcerated. It's like imprisoned. These are the ones that often cause a bowel obstruction because you got, part of the bowel that's stuck in that, and it just can't function properly, to make that, to make the bend as it goes through there. Strangulated, the intestine gets trapped and its blood supply is cut off. This causes severe pain, can lead to sepsis, and it's probably going to lead to them losing part of that intestine, when they go in and do surgery. Incisional, these are when there's been a previous surgery and a previous surgical incision through the abdominal wall, and this hernia develops through that. It's very similar to an evisceration. So it's, basically the cause is because of a previous surgery that's weakened the abdominal wall. Focus should be on supportive care, pain management as necessary to keep the patient comfortable. Watch for signs of sepsis. As with all of these abdominal issues that we deal with, the biggest long-term risk to the health of your patient is sepsis. This is especially true if the hernia is incarcerated or strangulated. Remember, these are the ones where we've had a protrudement of the bowel into that particular area, and either it can't function like it normally would, or the blood supply to that portion of the bowel has been cut off, and sepsis is the biggest concern with those. In-hospital treatment typically involves the reduction of the hernia, and either manually or surgically, depending on the type and severity of that particular hernia. So not everyone's going to require surgery, but about 1 million of them a year do. So a rectal foreign body obstruction will interfere with normal bowel movements. Now, these don't happen the way that everybody probably thinks that they do. The way that foreign objects can get stuck in the rectum happens in one of 2 main ways. Of course, one of them is through insertion. And these are often intentional, and it's pretty obvious what's happened. However, they can actually come from the upper GI tract, like objects that have been swallowed and they kind of travel down, and they get obstructed. And as they're trying to come out, there's an obstruction there, and it keeps it from coming out. If it's a foreign body and it comes from the upper GI tract, you might see sudden rectal pain when they're trying to defecate. And you may even have some peritonitis if the rectum has been perforated. So if there's a perforation there, we're going to lead to peritonitis. Understanding the type of object is going to be helpful, and whether they've tried to remove it themselves or not will give us an idea of the risk of a perforation having happened. Be sure to rule out, some kind of an assault or trauma that may have taken place. If perforation has occurred, be sure to keep a watchful eye for peritonitis and development of sepsis. Basically, the symptoms that we're going to see is mainly going to come from the patient's reporting of the pain. We're just not going to really find a whole lot physically on their body that we're going to be able to make a determination of what's going on. Of course, we're never going to try to remove anything. Pre-hospital care is just going to focus on keeping the patient comfortable. Have them lie on their side in the lateral position is usually helpful. It may be necessary to administer some pain medication. Watch their vital signs for changes and the potential development of sepsis. And of course, put on your best compassionate face and do not, don't be judgmental about what's going on or their lifestyle choices. So, ischemic and neoplastic disorders encompasses a few things. This is one that we talked a little bit about earlier, this mesenteric ischemia. This happens when blood flow to the mesentery, or what feeds all of the digestive tract, it gets interrupted and causes ischemia. This is similar to what happens in the heart with a myocardial infarction, what happens in the brain with strokes. And these mesenteric ischemias can become a mesenteric infarction where there's an actual blockage or an embolism. There's 4 different categories of this. Of course, it can be an arterial embolism, basically a blood clot that's traveling through those arteries and it gets blocked. And as you can see in this image here, depending on where it hits, it's going to have an impact of what portion of the digestive system it's going to affect, or how large of a section it may affect. It could be a thrombus from a plaque buildup or a fatty embolism. It could be a really bad vasospasm, so it might come and go. So things such as cocaine and norepinephrine and those things can lead to this. Or it can be a venous thrombus. It's a clot that forms on the venous side instead of the arterial side. You can look at this and unfortunately, these are not often detected early on. And when this happens, they can lose a very large portion of their, GI tract because it literally dies off before the problem is really detected. So with these, the symptoms can start gradually or suddenly. It's the gradual ones that are the biggest concern. The sudden ones usually raise the alarm bells a lot faster. And of course, this is really going to be dependent on what actually is causing the issue. So common signs and symptoms that we need to look for with these patients is severe abdominal pain that's really hard to pinpoint. Nausea, vomiting, diarrhea is pretty common because with that loss of blood flow, things aren't working properly. And there may even be blood in the stool. A really thorough patient history is really going to be helpful in figuring out what the cause may be and really just identifying the risk factors that the patient has and, to help determine, transport decision making. Rapid transport to a hospital that can, may be able to perform emergency surgery is going to be key. Excuse me. Monitor the patients closely, especially for signs of sepsis, and keep track of vital signs. If the patient shows signs of shock, remember fluids resuscitation is going to be key. If hypotension is due to sepsis, we're going to have to consider maybe some vasopressors to help stabilize the blood pressure. And of course, again, analgesics may be helpful in managing pain as long as it fits within your protocol or medical control is okay with that. Neoplasms, on the other hand, that can cause some obstructions these are just abnormal growths or tumors that happen due to errors during cell reproduction. And these neoplastic cells that are created, these rogue cells, they really don't serve any purpose. They don't do any good for the body, and they just use up resources. These can be benign or non-cancerous, or they can be malignant and cancerous, meaning they're trying to take over the world. They can also be primary, starting in the GI system, or they can be metastatic, meaning that they spread from another part of the body. So it just kind of depends. These neoplasms can actually develop anywhere in the digestive system or actually anywhere in the body. Colon cancer is the most common type of cancer in the GI system. And the cause of this is multifactorial, meaning it's due to a mix of genetic, environmental, and lifestyle factors. Some of these risk factors include having a diet that's high in red meat and low in fiber, and of course smoking plays a big role in this as well. There's a strong link between heredity and colorectal cancer, with one specific gene mutation giving nearly 100% chance of developing the disease, similar to the genetic link with some of the breast cancers as well. Inflammatory bowel diseases like ulcerative colitis, Crohn's disease also have a significant increase in the risk of colorectal cancer. The most common signs for colon cancer include abdominal pain, anemia, abdominal masses, and rectal bleeding. Screening methods like colonoscopies and those kinds of things can catch many of these cases of colon cancer before the symptoms even show up, when they're the most treatable. If the cancer happens to be found on the right side of the colon, patients often experience bleeding and diarrhea, whereas tumors on the left side are more likely to cause a bowel obstruction. Pre-hospital care, again, is going to be supportive. Ultimately, they're going to require they're probably going to require some sort of surgical resection of the colon for an ultimate treatment. In some cases, a colostomy may be required as well. Now, pancreatic cancers, on the other hand, remember the pancreas is an endocrine and exocrine gland. So for the pancreas, most of the cancers that develop on the exocrine cell side. For about 40% of the cases, there is really no clear cause. They have no idea what causes it. However, for about 30% of those cases, they've linked that back to smoking. And the remaining, kind of round out the remaining of them, has to do with diet, and then there's some heredity. People with diabetes may actually have a higher risk of developing pancreatic cancer as well. The presentation of pancreatic cancer is usually gradual, and it's often mistaken for other benign conditions. So we'll see kind of some very general symptoms like, fatigue and weakness and nausea, vomiting, maybe even some back pain or some weight loss. If the cancer is at the head of the pancreas and it blocks the bile flow from the gallbladder, it can cause dark urine, maybe pale stools, and even fatty stools. Depression is more common in pancreatic cancer than a lot of the other cancers, because of the low survivability rate. If the cancer spreads or metastasizes, it may lead to liver cancer and even eventually lead to liver failure. Of course, pre-hospital care is going to primarily be supportive again. Pancreatic cancer has a very high fatality rate, with survival typically ranging from about 4 to 6 months after diagnosis. Many patients with pancreatic cancer may have a living will or do not resuscitate orders, or they may even be on hospice care. So it's important to understand the patient and the family's wishes as you're kind of moving forward with the treatment plan. Liver cancer, on the other hand, it's a very rare thing, but it's actually more common in men. In the U.S., the primary causes or links to liver cancers is cirrhosis. So we typically see some kind of cirrhosis linked to the liver cancer. And the risk factors for these include things like hepatitis B and C, and as well as alcohol consumption are big contributory factors. The patient is likely to have already been diagnosed before we're involved in that. So we should expect some symptoms like pruritus or itchiness because the liver's not filtering things out. We're going to see jaundice looking skin and eyes, maybe an enlarged spleen, severe weight loss and malnutrition. They're going to have this fluid build up in the abdomen, so they're going to have ascites, so they'll have this kind of bulging or protruding abdomen. Abdominal pain is very likely, and then they'll have hepatomegalia or an enlarged liver. Patients may also show signs of cirrhosis or hepatic encephalopathy, which is that confusion or altered mental state due to that liver dysfunction. So there's going to be this disease progression can be rapid or it can be a little slower, but liver cancer is a pretty ugly thing to watch. Providing support for vital signs is critical. Place them on the heart monitor and monitor the EKG. Airway protection may be necessary in these patients, and as well as maybe even some positive pressure ventilation for the patient that's not breathing well. If you give medications, it's really important to realize anytime you're dealing with a poor working liver, make sure that you use the lower end of the doses of medications. This is especially true for those medications that you know are metabolized through the liver. Using those lower doses is important because that medication is probably going to stay in the system longer. And then you can always increase the doses as needed. In some cases, the liver resection, where they'll go in and they'll remove a piece of the liver, may be needed, and it may be warranted, it may work. Of course, talk to the patient and their family to understand if there's an advance directive or a living will or even a medical power of attorney, so that you can respect the wishes of the patient and the family. All right, so the last thing we're going to talk about is a little bit on preventative measures. A lot of the things that we've just discussed, there's some things that we can educate patients and the public about to, perhaps prevent or stave off some of these diseases from happening to them. Our role as EMS providers has begun to expand beyond us just dealing with emergencies, us just going out after all of these, terrible things have happened. The focus is starting to become a little bit more on prevention of injuries and diseases. Of course, there are several behaviors that can help prevent or reduce the severity of GI diseases. And these things include like eating a high fiber diet and keeping the fat intake low. Always eliminating smoking is a good idea, and avoiding alcohol consumption. And then, of course, reducing stress through practices like medication, exercise, and relaxation techniques. Ironically enough, for us in EMS, doing these things is probably good advice for us as well, knowing that it's a high stress environment that oftentimes has the use of tobacco and alcohol as a self-medicating habit. But our role has expanded to try to help prevent diseases and injuries rather than just responding to them after the fact. Okay, chapter 21 is officially in the books. Hopefully you got some good information out of that, and you'll be ready for your next exam.